what is the evidence saying and things like that, right? We all know that low back pain has it's a very common problem nowadays. The disability of due to back pain is getting larger and larger. Even in our clinic, we hear people saying that I have put leave and I have come here, right? So the absenteeism is also getting larger and larger. So back pain is getting a bigger problem, and we know that as Benedict has already enumerated, that we usually do what somebody taught us, right? We never do science. Mostly medicine is poor science and physiotherapy is really, really poor science. What I mean by poor science is we don't follow scientific principles. We follow whoever talks better, whoever can do a better course, whoever charges more money, we think that is true. Say for example, nowadays, when I studied, the fancy treatment was manual therapy. Afterwards it became, I don't know what it became. It became whatever people can throw money at, right? From acupuncture, they had, because acupuncture had a bad name, they called it dry needling. We all idiotically think that that's the new name, right? They move joints which cannot be moved, sacroiliac joint, the fascia, the cranium. So we have, those are all not poor science, those are just stupidity. That is not poor science. Remember that. That is pseudoscience. There is a difference between science and poor science and pseudoscience. Right? Say for example, PNF is a poor science. It was written in the 1950s, right, in the 60s, based on Sherrington's work. Sherrington's work was done in the early part of the 20th century. So it was slightly, at that time it was the best of the best. But as time goes by, we know that we have moved on, we have learned more, and we have moved on, right? That is what happens to science. It moves on. Whatever happens in 20 years back may not be true now. That is the nature of it, right? Science keeps on moving. But whenever they wrote acupuncture, they wrote it 2000 years back, we still do that. That means it is probably not true, or it is not evolving. If it is not evolving, we have to be very, very careful whether it has scientific merit or not. It may have, but we have to be very, very careful. So, how do I know that these are not good or bad? We know that there is a pyramid for evidence, right? What is the best and what is okay evidence, right? It's not that these are all, this is not to say that expert opinion is not evidence. It is just that it is lower level of evidence than systematic review. Am I clear? You should not be saying that, no, I will not listen to case report at all. That is not how it works. It is evidence, but this is poorer evidence, this is better evidence. What it means is what you are seeing in your clinic is also may be true, but you have to be very careful whether it is the actual truth, right? Because what you see, we all know that what we see is not the whole truth, but it is, there will be some parts of it too which are true, right? So there are different levels of evidence, and systematic review is, as we all know, is the highest level of evidence. And in case of low back pain, even though the systematic evidence is not very clear, mostly we have slightly lesser evidence than systematic evidence for low back pain, for most of the things. For some we have, for some we may not have, right? Next slide. So basically what the evidence is sort of suggesting, right? It is pointing in the direction. It is not conclusive. There is a difference between conclusive evidence and pointing in that direction, right? What I mean by pointing in the direction is, it is saying that these might be working better. It is not saying that these are the treatment. Am I clear? Say for example, if you have for tuberculosis, it may be sort of confirmatively saying that these are the good drugs which you have to use, right? This is basically pointing in this direction. What it means is another 20 years or 40 years, we may have more data to have, we may move closer to the truth. Remember, we are never at the truth. We are going always closer to the truth. That's what science is. So at this direction, it is just doing directionality. Okay, these are the things which might work better, right? So in case of back pain, there are one direction which says is, if you reassure your patient that this is not a big issue, don't worry, be active, these kind of things have the better evidence, right? And some amount of evidence towards exercise also is there, but again it is not very, very clear, right? We will also try to see why it is not clear, or is it we have to be nihilistic about it, or things like that also. The other direction which it shows is about drugs. It shows that probably not working at this point of time, right? So whether it is NSAIDs or other type of drugs for back pain, it may not be the ideal thing to give or to prescribe. The treatment doesn't work like that for back pain. And all sorts of passive modalities, they have poor evidence, whether it is traction or IFT, right? Now, when I say poor science, what I mean by it is, because we are unable to shed our low value care like passive treatment, because of many reasons. One of the reasons is we cannot independently say that this is the treatment we have to give. Somebody is always suggesting us that these are the treatment we have to give, so we are unable to leave the passive treatment also. The other thing is also that we just don't read also enough to leave alone the passive treatment also. Especially, I am disappointed with what the colleges are doing. In other places, there is no autonomy. Say, for example, if you are working in MGM, you have to, or if you are working in your house, you have to do what your consultant is saying. You cannot say, I will not do, right? So that is not how it works. But in case of colleges, mostly I think the teachers are either just too lazy to read or probably stupid, right? So if you are unable to change about those things, as I told you, when the science evolves and you are unable to change, that is poor science. It is really, really poor science, right? But if you are doing some things which are based on things which are no scientific merit, that's a different kind of kettle, right? So these are the two parts to it. One is, we think that, okay, some exercise, some amount of reassurance can be better, right? So we will try to see, okay, how will I do that? Now, one of the biggest problems in this era, what I have noticed, as especially nowadays, I am also, if I bored also, earlier I used to read, nowadays I am stuck with the Instagram and I am just ashamed of myself, but that is the nature of it. They all say that do this 5 exercise and do this 3 exercise, and I'm thinking, who the hell are you? Why are you so stupid, right? What does 5 exercise mean? Where is that coming from? Where is the principle behind? That is the difference between science and saying manjalayum injiyum karachi kudinga nu solradhu. That is the difference, right? If you ask why you should keep the first leg, if you are getting married, they will tell you to keep the right foot, right? If you ask why, they will be like, do what I am saying, right? That is not science, we know that. But you can follow it. I'm not saying that you should not. But the science is you should be able to explain to me why I am doing that 5 exercise. And what is it based on? Why I need that? Because if I have to change that, I need to know the principle, not the how to make the sambar. Am I understood? Okay, I don't have, today I don't have tomatoes. How will I make sambar? Probably put tamarind. because you need to know why you are adding tomatoes to get that sour and some sweet taste to your sambar, right? So if you don't know that, you will be stuck. So you need to know why you are giving this exercise. How am I going to formulate this exercise? So I need to understand the principles of how to give an exercise program, right? So that's what we will try today. It's a difficult process, but we will see whether it can be done. So there are two types of exercise. General fitness exercise. Again, it's not just me telling me that you have to give general fitness exercise. We know that a lot of RCTs have done that, and we know that a lot of studies have shown that if you give general fitness exercise, the patients with low back pain get better. Any general fitness exercise, it can be cycling, swimming, running around, walking, whatever it is, right? Probably, and good aerobic exercise seems to have a slightly better evidence also. Slightly better, it's not again the truth, but moving towards that direction. The directionality is there. So that is what we mean by general fitness exercise. Any aerobic exercise, if you can think of. Even if it is not based on your target height value or heart rate or something like that, still it seems to be working, right? And the next one is we have flexibility exercise. Basically all sorts of stretching, whether it is active or passive, but basically we are going to talk about mostly passive, active things rather than passive things. If you want, you can add passive also, but we will talk more about active things, right? So you have a group of exercise. A lot of people have given flexibility exercise, right? And then they give a exercise called a stability exercise, or I hate this word, but I have to say that it's called core stability exercise, right? Again, people who don't understand biology will call it core stability. Core means that it is in the center, right? Because they thought that it is in the center, it has something else. It is core and it is useful. That is not how biology works. We know that biology is based on context, and also remember, when I am standing, I am anchoring to the ground. This is not anchoring to the ground. This is anchoring to the ground. My foot is anchoring to the ground. So you should not be thinking of this is the middle, this is the end, and this is the top. That is not how biology works. Again, very poor understanding, poor science. This is why after 20 years of doing RCTs, we are nowhere near anywhere, because we are just extremely stupid in terms of defining things, in terms of understanding how things works. We just use already existing paper. They call it as mother article, right? That means you are already useless. Already somebody has done something and you are going to do something about that. That means it's of no value to anybody, right? So you have to make it better than what already has done. That is the whole idea of science, right? So it has to be incrementally changing. But if you change something, your teacher or your guide or whoever will ask, who asked you to do this? Where is the reference for this? That is what we have become like that, right? And also they have a group of exercise called as motor coordination exercise or motor control exercise. Again, I hate that terminology, because coordination by, can anybody define what's a coordination?
Timing activation.
Timing activation. Okay, and?
Speed.
Okay, speed for what?
Specific task of reaching.
Right. For a task specific activity, there should be a timing and speed and accuracy, right? So if you are talking for this for a back pain, it is very difficult to say what task they are doing, right? Are they bending? Are they going like this? Are they going sideways or going this way? It's slightly difficult to say what task they are doing and which task this coordination is poor, right? We all know that a gate, all the phases of the gait and things like that will only work when you define that the patient is walking on a straight surface and a smooth surface. If you are going to make him walk in the outside, right, in the uneven surface, the whole faces will go change drastically, right? Because you'll have more pronation, supination, and you'll have more rotation of your hips and knees, which we don't usually talk about when we are talking about gait, because it's easier when it is in single plane rather than multi-plane. Right? So it's slightly difficult to do that. But anyway, there is a group of exercise called as motor control exercise, based on the idea that some muscles don't activate. That's where the core also started. Mostly, if you see that there is a guy called as McGill. If you have heard about McGill about back pain, he also started the idea of these are the 3 exercises we should be doing. They have actually McGill 3 actually. So that is based on the idea that some of the muscles in the surrounding your trunk is not working properly or not coordinating enough. And then we have strengthening. Again, that's what we all wrote in our exams. We said that we do strength training, right? So we will try to understand what is the idea behind any of these or all of these things. We will start with the next one. We will start with the understanding of what we mean by specific and non-specific exercise, because at this point of time the evidence is saying that there is no difference between specific exercise and non-specific exercise. Any exercise is good exercise for your your neck pain and your back pain. It doesn't matter whether it is flexion or extension or this or that. It doesn't matter at all. It seems that if you do exercise for 20 minutes or something like that, it's a good exercise. They get better with or without exercise. So the first part is called as the non-specific part or non-specific exercise. Commonly they do this for chronic back pains or chronic neck pains. They mostly give you non-specific exercises because they have to do it for a longer time. Specific exercises are difficult to do for longer time. Say for example, if I ask somebody to do neck exercise it will hardly take them anywhere from 2 minutes to 4 minutes. Or probably 5 minutes. I can't ask them to do for 20 minutes or something like that. Very difficult. So mostly they tend to do it as a non-specific manner, especially in chronic pains, right? So the other things are specific. They are specific to your back. Say for example, for neck pain, mostly they give you exercise for neck and your scapular region. That's the common thing we all have to do. That's what everybody does. Right? Because we know that these two has to coordinate together to get a better activity. In case of back pain, mostly the hip and the trunk has to be exercised together. So that if you do that, that's called as a specific exercise. And if you do it for the whole body, like cycling or swimming or running around, these kind of thing, that is called as non-specific exercise. There is no principles involved in non-specific exercise except for it has to be done for a certain amount of time. Probably if you are thinking of it as an aerobic exercise, you have to think of your target heart rate and see whether you are doing it in low intensity, high intensity, medium intensity, that kind of moderate intensity, that kind of thing. So we are not going into non-specific. We will talk about whether there is anything we can make it better to understand how a specific exercise can be made better for us. Next one. So we will start with strengthening because I think all exercises come under strengthening. Even though I am still not very clear, you have to call it a strengthening exercise. But we will try to understand slowly why and what and things like that. Right? Now we can have strengthening exercise which are, what do they mean by strengthening exercise? You have to first define that. Remember when we study undergraduation, we don't have principles of exercise therapy in there, right? But we have a national syllabus also which doesn't, I don't know why. That is because we keep on writing, thinking that the Didion Gardner is a good book. That's a toilet paper, right? So if you are thinking of strengthening exercise, they have to be thought of again as whether you are going to do for the whole body or for individual. Here we are going to talk about individual. When we are talking about individually, we have to remember when it is back pain. Sometimes they do it for your trunk and your hips or just your trunk, right? Now, how do you define it as a strengthening exercise? What are the principles of strengthening exercise? It has to be progressive, right? That's one thing. Okay, what else?
Frequency.
We will come to, okay, frequency, intensity, time. That's called as a fit principle, right? Okay, what else? Load, overload. Overload is the principle, not the load, right? We have to overload your system rather than load the system, right? Now, this is a first problem you will meet in case of principles of exercise therapy for any condition, especially for back pain. Chariya? Okay. How many times you have to do back exercise? Say for example, if I am going to do exercise, extension exercise, how many times I have to do? Frequency, we'll start with frequency. How many times do you usually do? 10 to 15, right? Okay. What is the load they have? Gravity, right? So you are basically treating them as though they have muscle power. What muscle power? 3 or 4, right? So probably there is no overload, right? What else? Timing, what is timing?
You are timing from the patient side also. 2 times a day, so 3 times a day, what are you prescribing?
Okay, so how many times are we prescribing? What schedule do you mostly have?
2 times.
As many times as possible. Good idea, but we know that nobody listens to that, right? And also remember, if you are prescribing something, you want to have some amount of, that's a good idea. I'm not saying that that's a bad idea or anything like that, but we again don't know what is the better timing. How many times is it better to get recovery? Is it as many times as possible, or is it twice or thrice, or we don't know that also. Say for example, if I am telling you that you have to take metformin, right? We will assume metformin. They will not say that how many times you want you can take metformin. That is not how medicine works. We know that 5 grams or 10 grams, they will be very, very specific, right? So we also have to be specific. Sadly, we think that those are not needed for us because we are beyond that. Or we think that that is not under our control. Or we think that that is not science. That is the point of it. You have to be specific. If you know F or if you know MA, you will know that you can find out F because they are all constant, right? So we should have some amount of specificity involved in all these things, and we know that even in the studies which says that they are doing strengthening exercise, hardly they do strengthening exercise. They hardly do strengthening exercise because, as I told you, if you do 10 times for your back, if anybody goes to the gym, they will know that that is just warming up. It is not even warming up. It is not enough for you to strengthen any muscle. Okay. Then you may think that, but the patient has pain, so he is having difficulty in moving, right? Is it possible? Then should we call it as strengthening exercise or something else? Sorry? I don't know what to call it, but that seems to be a good answer. Pain specific movement or directionality movement. We will try to find out all these things, right? Okay, we are going to do strengthening exercise. So what muscle has to be strengthened? Sorry? No, we have to be specific because we know that we are not talking about whole at this point of time. Non-specific, we are not talking about non-specific. We are talking about specific. So if I say whole, of course it has to be whole, but what are the muscles? If you go to gym, even nobody goes to gym and exercises each and every muscle. That's not happening, right? So what are the common muscles we tend to think of as strengthening exercise? Extensors of the back, right? You can be specific about this and that muscle, but I am pretty sure that is not how motor control works. Even though a lot of people tend to think that you have to activate your multifidus, transverse abdominals, and again from the McGill idea and the Paul idea, right? But we know that if you're doing this, right, for your transverse abdominals, that is not strengthening exercise in any imagination of time, right? If you're doing that and you are trying to activate your transverse abdominals, you have to be doing it for probably 500 times for it to be called as a strengthening exercise, right? So, okay, we are going to activate what are the muscles? Back exercise, what else?
Glutes, hip extensions,
Glutes, hip extensors, abductors, not abdominals, side muscles. Huh? Okay, SLR, I will try to, why SLR? Huh? Hip flexors, okay. All right, so we will come to the specific exercise also. So we think that some people tend to think that we have to do extensors. Again, at least that's what I learned when I went to school. We usually did exercise when I went to college, not unlike now, where exercise is considered as secondary. The first thing is IFT or something, right? Traction or something like that. When we went to school, it was both. It was, no patient left the clinic without doing exercise. The exercise were subpar, don't take me wrong. It was subpar, but they did exercise, right? We usually, some of them will remember, we usually did extension exercise. We never did flexion exercise, right? That is based on the idea that there is a pathology in the spine, right? Again, but nowadays we don't think like that, because we now know, or we now believe that it is difficult to find out the reason for your back pain, even though a lot of people tend to think that they can find out the reason for back pain. If you can find out the reason for back pain, you can apply to Sweden and get your Nobel Prize, right? They are waiting for you. You might be the greatest scientist of this era, right? If you think that the spine is coming out, the disc is bulging, your transverse abdominis is not working, your multifidus is not working, you need to try to read and change what is happening to you, right? You cannot be in the same idea as it used to, right? Anyway, so we think that nowadays we have to activate your abdominals, probably your side flexors, your hips, because we know that the pelvis and your trunk tend to move together, so probably you have to activate all your hip muscles also. So in case of studies, what is the problem in the studies is we are not sure first. As I told you, this is basically activating your specific muscles, activating your transverse abdominals, your rectifidus, multifidus, and things like that, right? Even when I went to low back pain course, probably when did we go to college? 2006, right? 3. When we went to 2003, there was a guy from UK who came and taught us low back pain. Sadly, he was a very good friend and he died some years back. He was teaching us about activating your multifidus, your transverse abdominals, and things like that, right? Now, again, I am not sure in what position you have to activate these muscles. Am I supposed to do it when I'm sitting like this, or when I'm standing, or when I'm doing my movement? We are not sure, or at least I am not sure when we have to do it, all those things. Even if I am able to do that, is it going to change my functional activity? Again, I am not very sure. The studies are also not sure they can show any of those things, right? And in case of strengthening exercise, there is a problem with why they are activating any of those muscles. I am not sure it is clear in the studies also to say I am activating these muscles because of this particular reason or that particular reason, or I am leaving out these muscles because of these particular reason or this particular reason. And some people are extremely specific. They have this syndrome called as piriformis syndrome. I don't know why people come up with whatever nonsense they can think of, and they activate only the piriformis, right? As though that muscle alone can do something in your body. That is never how biology works. We know that your brain does not activate a muscle. It activates movements. It activates a task. It does not activate a muscle, a joint. It doesn't work like that, right? So you cannot be specific. At the same time, you cannot be, I am not sure whether the studies are telling what are the muscles have to be activated or strengthened, how they have to strengthen, and also, as we have already explained, none of the studies except for very few are in the fit principle. They don't tell us the intensity properly, they don't tell us the timing or the frequency. And when it comes to overload, as he has pointed out, SLR is not an overload exercise. There is no overloading your hip flexors, or if you are trying to activate. This is only in the context of strengthening exercise, not whether it is helpful in your treatment. That's a different question. Am I clear? Right? And even if you are talking about back exercise, again, I am not sure any of it is a strengthening exercise, because it hardly overloads. It hardly has the enough frequency for you to get a good strengthening of the muscle. The next point, what is missing is, okay, we will assume that strengthening is happening. How is strength changing the pain and function of a patient with back pain? What is the correlation between strength or activating any of these muscles and pain and functional activity? How do we think? Sorry?
Even simple movements is reducing the pain.
Right. So, simple movement is reducing the pain is a different thing. That is what we call as non-specific. Right? We will come to that also. But we will be specific now for why strengthening is a superior exercise, if you will. How is that influencing? Say, for example, we know that they activate transverse abdominis, multifidus, and things like that, right? How is that influencing your pain and function?
Facilitating
increase the capacity of the muscle to take up load.
Take up load. Doing what? Like what exercise? What activity?
We say to
Mostly what do our patients say when do they have pain? Bending down. What else? Lifting weight. Okay. What else?
prolonged sitting.
Prolonged sitting. Okay. What else? Driving.
By
Walking.
walking.
Right. So, sorry. Lying on the supine. Sometimes they tend to also do. That is slightly outlier, but mostly these are the things which we already have. So, if you are sitting for a long time, right? Do you need, what type of strength do you need?
Endurance.
You need endurance exercise. Again, people have also tried that also, and that also doesn't seem to have a positive value out of it also. So if you are activating it, as I told you, once or twice, can it lead to a better endurance while you are sitting or standing? We are not sure. It might happen, right? Okay, what else? Okay, we will talk about increasing the flexibility, and then okay. So if I have already improved this flexibility, what is my strength doing then?
Stability.
Stability of what? Stability of what? Because the problem here happens because we assume that the spine is. Who told us that? How did we find that the spine is unstable? Because if I say my knee is unstable, we have hundreds of tests to find out, right? Right? We have better tests actually, right? But here we don't have any of those things, but we assume that the spine is unstable, right? Because we think that that is the pathology actually. It may or may not be, we are not very sure, but I am pretty sure it is not. But we think that the spine is unstable and then we try to do strengthening exercise. Again, why I am trying to tell all these things is, this is the lacunae in the current understanding of why we are giving exercise. If you have a better understanding of all these things, we may come up with better evidence actually. We may actually have a better treatment for our patients, right? So, whenever I am thinking of strengthening exercise, there are two problems. The first problem is, whenever any patient who comes to me and they say that, no, they taught me exercise, I will always tell them, okay, please do it. And they do, if it is for OA knee, right, they do isometric exercise for the knee joint, right? If I have to strengthen my knee with isometric exercise, how many repetitions do I need? Thousands, right? Has anybody tried doing 100, leave alone 1000? Because I have tried and I was bored after 10, right? It was really, really boring. I was trying to do it when I was doing my meditation also. So I thought that, okay, let's try this rather than focusing on my breath. Can I focus on my isometric exercise? I was extremely bored. When you're focusing on your breath also, you're bored. And this one was extremely boring because it was difficult after some time, right? But if you run 100 times or 100 meters or 5 kilometers or 10 kilometers, it is not actually that boring, right? So if you are doing SLR as we know that that's the common exercise, or if you are doing bridging, right? We know bridging is a better exercise. There is no two ways about it. But it hardly strengthens anything. Because again, you have to do it at least 100 times for us to get a good strength, if you are talking about frequency, especially without overload. Because you are not loading it with anything, right? You are not putting a bar in it and lifting it with that. That's not happening. So if you are doing it with that, so you have, okay. So we have to be trying to have a different word for what we are giving as an exercise, right? The next one is the flexibility exercise, right? So what flexibility exercise has to be given, again it is fairly simple. The principle is fairly simple. I am not saying that you have to give only for your piriformis or only for your reflexors or only for your extensor or anything like that. You can actually ask your patient and try to stretch whatever they are having stiffness with, right? If it is global, that is, if you are talking about moving all your joints in your trunk and in your hip, you do all the movements, right? You can do it as a sustained movement or repetitive movements, right? For flexibility, a lot of people think that you have to stretch it for quite some time and hold it. It does not have to be like that. You can just do it 100 times or 10 times or 20 times. It will actually start moving. Because remember, when you are stretching, you are not stretching the muscle. What are you doing? Very good. So basically you are changing the threshold for stretch reflex. You are not changing the length of the muscle as such. You are allowing the brain to relax and not activate the stretch reflex. So you don't have to be doing it in a sustained way. You can just keep on doing. That's what basically your warming up is. You just do it for 100 times like this and like this, and then you start running. It's always slightly easier than just stretching, right? So flexibility exercise has to be in all directions. Whatever muscles are, you think from hamstrings to hip flexors to your side flexors, all muscles has to be moved as such as a free exercise or free exercise with holding that position for quite some time as a sort of a stretching exercise also as can be done, right? So this is the problems which we have. So if you have to think of, how many of you have seen patients who do exercise and get better? Right? We know that that is happening. There is no two ways about it. Just that our nomenclature does not seem to be in the right direction also. We also don't know how many times we have to do. What is the frequency? What are the muscles which are better to be activated, or what are the joints we have to do? Right? If I ask you what are the exercises we all do, I am pretty sure everybody will say a different exercise. Right? That is poor science. Correct? If I ask you what is the treatment for diabetes or malaria, or, we all should have similar answers. It should not be the same, but similar answers. Right? But in physiotherapy, we are proud to say that no two patients will, or no two therapists will have the same answer. That is the poor science part of it. Right? Why? Because we tend to do exercise which our senior did when we were in college or in our clinic. Not that he told us what is the principle behind it. He just told them, okay. When the monkey put the you know the story of the capsular and the monkeys, right? We are all monkeys basically. We do what we see, right? If our father and mother are corrupt, don't worry, we will be corrupt. So if you want your children to learn good things, you should not ask for moral science in school, because your teacher is corrupt, your school is extremely corrupt, your college is fully corrupt, right? So nobody is learning anything from these people. So you have to be, they are going to learn from you, so you have to be proper, right? Likewise, the exercise what we learned is also by seeing rather than by having some idea. Now tell me what exercise we should be doing and what are the principles we should be following. We will call it strengthening exercise if you want, but then we will find out what name we can also give, right? So what are the exercise principles you think we should follow? Okay, overload and repeatability, there is no two ways about it. These are the two important principles, right? We have to do it again and again. One movement is not going to change anything. So you have to have a lot of frequency. We will see intensity about timing, we will see later on. But we know that there should be overload and there should be probably repetitions, right? So directionality, what directions should be the movements?
Movement is not aggravating.
Okay, you want to do that or you want to go into the pain?
Do it with the graded pain.
Probably you have to do it in the graded manner, right? Into the pain or away from the pain?
Into the pain.
Probably into the pain, because we know that slowly adaptation is one of the key principles of nervous system. So you want to go slowly into the pain rather than away from the pain. That does not matter. We can also go away from the pain also, but slowly you have to slowly go into the pain. That is basically what Maitland also wrote also. There is no two ways about it, right? Okay, you want to do what are the movements we think we should be doing for your trunk, say trunk, or your, I don't want to use this word spine, so I'm trying to be very, very hard to use another word called as trunk, right? You can think of it as spine. Enna movements la irukonu. What are the movements it should have?
Flexion.
You should have flexion, right? Okay. Before that, that is where we are going to start. What is, when you're talking about exercise therapy, the first question they should ask you is starting position. What should be the starting position? Standing? Who has ever given exercise in standing for low back pain? 1, 2. Now everybody is thinking, okay. Right? Starting position. Because that is what exercise therapy is, right? We have to start with what is the starting position of the patient, right? So, what should be the starting position? Sitting? Supine lying. Okay. So, how will we define or decide what is the starting position? Leave alone what we are doing. How will we say that this should be the starting position?
Pain activation.
Getting pain.
Sorry?
The question like
Getting pain.
Okay, that seems to be a good principle. Okay, what else? It cannot be one principle, right? That should be more.
Relax.
Relaxed position, not really, but anyway, we will have that also. Okay. Irritability, that's what I think he means by pain, right? What else?
Which question going to relieve?
Okay, we will see that. That's also a problem in supine also. If I say supine, there are a lot of movements which cannot be done. So we will think about that also. Okay, what else?
Less challenging.
How do you mean by less challenging?
In the sense,
Numbers has to fill.
Sorry?
For example, if you're prescribing for 20 times, the patient has to finish for 20 times with the same posture.
Mm-hmm.
Because of that, you have to make the patient be more comfortable position.
Okay.
less challenging means
Hmm.
the stability is broader, so we can be more like giving assistance to the difficult exercise,
What do you think is a difficult exercise?
which is more dynamic or functional,
Give me an example.
like reaching.
Reaching, do we want to do reaching exercise for back pain? Okay, what reaching exercise and how will it that?
Reaching overhead.
Okay, with or without weight?
Yeah, because we pain is coming up, so probably I will start in the position where it is provoking.
Okay,
Like if bending is painful, I will start in a less challenged position where they can.
okay. What else?
The context is strength training, so I have to add at least the gravity.
Exactly.
Yes, gravity.
Right? So if there is strength training, at least there should be a gravity as a component, right? We cannot say that I will start in lying position or sitting position or something like that, where the gravity does not come into play at all. That means that you are just asking them to move, right? But you can try it also without gravity also, that's okay. But I'm just saying that these are the problems in our thinking.
In severe pain, do you stop?
That doesn't matter. There will be always somebody who cannot do that. That is not a problem. If for example, no, I'll just tell you, that is okay. I'm not trying to tell you that that is not a problem, but have you ever tried a severe patient with standing position? Exercise start பண்ணிருக்கீங்களா கேக்குறேன்.
Yes, I am.
I have tried. That is the problem. We think that it cannot be done. Because we have not tried it, we think that it cannot be done.
Severe pain, I will not do it.
You will not do, that is not I'm asking. No, I also didn't do. Don't take me wrong. When I went to college, we didn't do. Right? But I'm just saying that we just don't do it because we think it cannot be done. I'm not saying that it is good or bad, and I'm not talking about that. We think that it cannot be done. Right? But as you have already said, we hardly do overload principle. But we still think that that is not possible. One of the reason I think it is possible is all my patients with back pain come walking, right? Why do I think I cannot do exercise like this? Because when they walk like that, right? My trunk was rotating. Clear? So we have to be wary of what we are thinking and what is happening to us, right? As I told you, all our patients are already coming by walking. So that is where the problem with challenging itself is a question. Already they are reaching for something when they are coming inside. They reached for the auto, or they put their legs like this when they were sitting on the bike. Some people might not be able to. I'm not telling all patients are like that, but most of our patients are walking properly and coming inside. Some people will have difficulty in sitting, and we know that people sit like this, right? So if you do 10 times of sit and stand, what will happen? They will improve.
Same depends upon the pain.
No, it does not depend upon the pain because it depends on the neurology of the pain, not on the pain. The neurology says that if you do it again and again, it gets better in back pain, not in
Right.
exactly, not in radiculopathy. We know that it does not work in radiculopathy. We know that it does not work in any infective disease. Clear? We have to be very, very clear with that understanding. சார் வந்து ஒரு நாளைக்கு 50 பேஷண்ட் பார்ப்பாரு, அதனால ரொம்ப கிளியராக இருப்பார். We don't see those kind of numbers. We have to be very, very clear of our understanding. Right? Lot of conditions it will not because the pathology itself is extremely different. Clear? So, what should be our starting position? How will we define our starting position? What is the principle based on starting position? Remember, some patients may not be able to stand at all. I'm not saying that that patient has to be made to stand. You can make them sit and do exercise. There is no two ways about it. There is always an outlier, right? But we are talking about the median part of it, not the outliers, right? As I used to say that we know that lot of students don't have to come to school or college. They will be brilliant, and then we will have some students who come every day, and they will be last in the class. Right? We are not talking about those people. We are talking about the median. People who come to college, they get better. That kind of. Okay? So what should be the principle of starting position? Okay, I'm not trying to answer any of these things. But this is where I think that's why we are not getting enough data from the researcher. We are not telling why we chose that starting position. Why didn't we choose this starting position? For me, the starting position should be slightly above your patient's ability or at your patient's ability. So all patients are walking and coming to me. If they are walking to me, mostly I start with standing position or sitting position. I never go to lying position. I will go, there's no question about it, but I'm just saying that I also give exercise in standing and sitting position also, right?
Different modes of exercise have reached
Correct.
the same outcome.
Correct. I'm trying to be slightly task specific. Am I clear? Because most of our patients are telling when I'm bending and I'm having problems, I am treating that in a standing position rather than lying position, supine and then bending. It doesn't matter. I can do that and then come here, or I can come here and then go there, whatever it is. But that is the idea I'm trying to say, right? So it should be. It should not be less challenging for them. So I think SLR, isometric exercise are all extremely less challenging for most of our patients. Some patients may have a lot of pain, so we may have to start with isometrics or something like that. But most of the time it should be slightly in a challenging position, should be or slightly at the level of the ability of your patient. At the level of the ability of the patient, they are walking and coming, so I think it should be all right for us. Clear? So the next question is, we are clear that we are not doing strengthening exercise, right? We don't seem to be doing strengthening exercise, but we are doing exercise, right? We can also do strengthening exercise also. If you give a kettlebell to your patient, that is a strengthening exercise because there is a overload principle, right? So we need to have what directions our movement should be. We know already said that we thought that the movement should be into the pain and also moving the resistance, right? If there is stiffness, you should move the stiffness. If there is pain, you have to move into the. So basically what I think should be done is we need to move the trunk in all directions, right? So forward and back, sideways and rotation, right? If you do it with a resistance, I think it's slightly better. Again, not all patients will start with a bigger resistance in the first day, but that's why we call it as progressive exercise, right? Progressive strengthening exercise or something like that. Again, I'm not sure whether it is strengthening exercise, but progressively it has to be there. So I think we should move the trunk in all directions. We can do it in sitting position, standing position, or lying position, but it has to be moved in all directions. One of the problems in lying position is doing rotations is slightly difficult in lying position. We can do those things also, but it is easier in standing position rather than in lying position, right? So you can do it if you are doing it as a strengthening exercise. You need to have an overload. You should slowly increase the load. So for at least in my clinic, what we do is we start with a 2 kilograms ball and then slowly go up to that 8 kilograms of kettlebell. That's what we do. Again, it is not based on the duration. It is based on, as we already have discussed, the irritability of the joint. The less the joint is irritable, then you can go faster. If it is more irritable, you have to go slow. Again, this is poor science, but that is where we are at this point of time. Right? We should be able to have some amount of definition of when I can go to full strengthening and less strengthening. We don't have those things. Say, for example, if you have motor neuron disease, if you have grade 3 muscle power, we know that what are the exercises we have to give. Right? But here we are not very clear about that also, right? Or at least we don't know what is the parameter we have to check for, right? And also we know that we also have to move your hip also. So you have to do hip exercise probably again in all direction. Abduction, adduction, flexion, extension, some amount of rotation. Again with resistance, again I usually give with resistance rather than just free exercise. Again, sometimes we start with free exercise and then go into rested exercise also, based on the irritability of the patient also. Again, some patients may have to start with the lying position because that is itself is more challenging for them rather than standing positions. But I rarely had to go there. Mostly we are able to do it in standing itself. Again, what do we call this? I am not sure at this point of time. Probably a free exercise is a better word rather than calling it as a strengthening exercise. Or a rested exercise. Again, I'm not sure it is strengthening the muscle because for that we need frequency, intensity and timing, which we are unable to define at this point of time. Right? So,
strengthening the synergy of moving.
If you are defining synergy as for a task, it is difficult to do that also. Say for example, if I'm going sitting and standing as an exercise, right? A lot of people don't have difficulty with sitting and standing when they come to a clinic, right? If I do that, that can be a synergistic activity. But if I'm just doing flexion extension, I'm not sure we can call it as a synergistic activity.
It mimics most of the.
It mimics activation of group of muscles, not necessarily a synergy. Right? So if you have to do an exercise, I think we should not be thinking of just I'm strengthening these muscles, I'm strengthening the core, I'm just moving these joints and things like that. We have to have a slightly broader view, as I told you. What I mean by a broader view is exercise does not just increase your muscle power. It does a lot of things. Primarily, it does two things. We all know that the nervous system does two things primarily. One is inhibition, another one is excitation. Right? So you have to use these two principles for you to when you are thinking of exercise. We know that pain is a inhibitor or an excitator. Inhibitor. So we have to activate those muscles to excite the excite that. And we also know that pain can be inhibited, so we have to activate your the what we call as the descending tracts for your pain modulation, right? So both of these things are happening when you are doing exercise, right? இப்போ உட்கார முடியல இப்போ மெதுவாக இப்படி பண்ணுறாரு அப்படின்னா வந்து his mind is also getting relaxed every time. His joints are moving, his muscles are moving, there is some amount of inhibition happening. Suddenly you will get a pain and then he will go like that. Again you have to go slowly again into those movements. So you have to have it as something like this. Probably we are increasing the strength, but I am not sure when this is happening because we know that strengthening happens after 6 weeks or 8 weeks. right? We know that we are changing the tension of the muscle. That is what I mean by the inhibition is there, so we are trying to excite the muscles, what we call as protective spasms. So we are changing that. If we are improving a coordination, again that's what we mean by synergistic activity and things like that. Probably not, or it depends upon what type of activity you are teaching our patients. Right? If you're teaching them sit to stand or things like that, it might be happening. I'm pretty sure we are not changing the pathology, so there is no increasing instability, or the disc is not going inside, or your ligaments are not all or getting this and that. I'm pretty sure those things are not happening. So what I think is mostly it reduces the fear of movement. So it increases the, that's why directionality seems to be an important factor. The directionality means that in which direction you are moving, right? So we are slowly decreasing the fear of movements. That's what we mean by exciting the muscles and the joints and the synergistic activity of the muscles. And we know that there is certain amount of desensitization. If you keep on doing it, the pain gets desensitized. You are activating your anterior, your frontal cortex via your anterior ACC, what is that called as cortical, and then it goes from there to your limbic system, from your limbic system downwards, right? So that happens when you are thinking, okay, I'm able to move. I was thinking that back pain is bad and I am now slightly better. That means you're activating your frontal cortex. If you are teaching a patient some movements and you're thinking, now try what are the movements which are painful, now try, he's thinking, okay, it's slightly better, then you reinforce with your talking of your patients and thinking that I am the greatest therapist kind of talk to him. And then he is like slightly relaxed, right? So whenever you are doing an exercise, remember it is not just activating your body, it is also activating your mind also, because your body and mind are the same, right? A lot of people think that these things are two things. Like your kidney is yours, which is inside you. Your brain is also inside you, so it is not outside. So whenever you are doing your exercise, you are changing your kidneys, you are changing your liver, and also your brain. All things are changing. So whenever you are relaxing better, your movements get better also. We know that endorphins and all those things are also activated, right? So if we have this kind of slightly broader understanding of how to do an exercise and whether this exercise is better than no exercise, that kind of idea, we may get slightly better data than just saying that I'm doing a McGill's exercise, or I'm doing McKenzie exercise, or this exercise, that exercise. And by any stretch of imagination, we have not covered everything which there is a lacuna in it, but whatever I thought is slightly valuable, I have tried to add to it. So if you do all these things, then I think is the principle of exercise therapy, rather than saying this is what I do in my clinic and this is what I should not be doing, and all those things. Right? If you have that principles in our mind, we may have a better therapy. Right? Do you have any questions before finish?